I'm recording another concept in perfusion. This one is on heart failure. So looking at the overview of heart failure, it is a condition in which the heart is unable to pump enough blood into circulation to meet the body's needs. It is a progressive syndrome. It develops progressively over time as the heart muscle becomes weaker. It can become acute or chronic. It leads to a drop in cardiac output. This leads to decreased tissue perfusion. There are some compensatory mechanisms that are activated to restore tissue perfusion. This could result in vascular congestion, hence the name congestive heart failure. As mechanisms are exhausted, heart failure ensues with increased morbidity and mortality. Pulmonary edema is an abnormal accumulation of fluid in the interstitial tissue and the alveoli. It has both cardiac and non-cardiac disorders can cause pulmonary edema. Some of your cardiac disorders are going to be an acute MI, acute heart failure, valvular disease. Your non-cardiac disorders include acute respiratory distress syndrome, trauma, sepsis, drug overdose, and neurologic events. Pulmonary edema is a medical emergency. Basically, they're drowning in fluid and they need immediate treatment. Looking at the pathophysiology, mechanisms activated to compensate basically when the heart begins to fail. Their primary compensatory mechanisms include I'm going to talk about the neuroendocrine responses first because it has something to do with the Frank-Starling mechanism. So looking at the neuroendocrine responses, the activation of the sympathetic nervous system and the renin-angiotensin system is done to increase renal perfusion. The sympathetic nervous system releases norepinephrine, which causes an increase in heart rate and contractility. Cardiac output improves as both the heart rate and stroke volume increase. Norepinephrine also causes an arterial and venous vasoconstriction and increases venous return to the heart. In the Frank-Starling mechanism, the increased venous return increases the ventricular filling and myocardial stretch, increasing the force of the contraction of the heart. So basically, the greater the stretch of the cardiac muscle fibers, then the greater the force of the contraction, and that's the Frank-Starling mechanism. In myocardial hypertrophy, increased cardiac workload causes myocardial cells to hypertrophy and the ventricles to dilate. Patients with heart failure have no minimal cardiac reserve left. Activity intolerance when the client at rest indicates a critical level of cardiac decompensation. So this is showing you a normal heart versus one with heart failure, and so you can see that dilated ventricle that we were talking about. Some of your classifications of heart failure, you can have systolic versus diastolic heart failure. And systolic heart failure is when the ventricles fail to contract adequately to eject a sufficient volume of blood into the arterial system. In diastolic heart failure, this is when the heart can't completely relax during diastole, disrupting the normal feeling. You also have left-sided versus right-sided heart failure. In left-sided heart failure, this is caused by coronary heart disease and hypertension. Left heart failure can lead to right heart failure. As the left ventricular function fails, cardiac output falls. Pressures in the left ventricle and atrium increase as the blood remaining in the ventricle after systole increases. This causes congestion and increased fluid movement from the blood vessels into the interstitial tissues and the alveoli. So that's when you're going to have lots of fluid in their lungs. Right heart failure is caused by acute and chronic pulmonary disease. In right heart failure, you will have increased pressures in the pulmonary vasculature, or right ventricular muscle damage impairs the right ventricle's ability to pump the blood into the pulmonary circulation. The increased venous pressure causes the abdominal organs to become congested and peripheral tissue edema. So this is when you have swelling in the lower extremities. Then you also have low output versus high output failure. In low output failure, the heart failure from CAD, hypertension, cardiomyopathy. In high output failure, it is from hyperthyroidism, infection, anemia, pregnancy. These require an increased cardiac output to maintain blood flow and oxygen to the tissues. So if the body can't meet the needs, then high output failure develops. You also have acute versus chronic failure. In acute, this is an abrupt onset of myocardial injury, and this is usually from a massive MI. Your chronic heart failure is a progressive deterioration of the heart muscle from cardiomyopathies, valvular disease, and CAD. In cardiogenic pulmonary edema, contractility of the left ventricle is severely impaired. The ejection fraction falls because the ventricle can't eject the blood that fills it, and fluid enters the interstitial tissue and the alveoli. All right. So this is looking at the difference between systolic heart failure and diastolic heart failure. And so you can see the difference even in the ventricles, how in diastolic those muscles sort of get thicker. And you have less blood that fills the ventricles, and it can't relax as well. In your systolic, you can see the lining of the muscle is thinner, and it can't squeeze as hard, and so that's why the muscle has basically just sort of atrophied. Then it's also showing you the difference between right-sided and left-sided heart failure, and it kind of goes along with right going congestion of the peripheral tissues, which we talked about, swelling there. So they may have edema, ascites, liver congestion, and impaired function, GI tract congestion. And so that's why it affects the abdominal cavity and the peripheral tissues. In your left heart failure, you have that decreased cardiac output, and remember that that's going to give you that pulmonary congestion. So you've got that cough with a frothy sputum, that gives you that paroxysmal nocturnal dyspnea, orthopnea. A lot of times you'll hear crackles in the lungs as well. Etiology. Some of the causes for heart failure are going to be ischemic heart disease, cardiomyopathies, hypertension, your congenital and valvular heart disease, a history of an MI. Incidence and prevalence increases with age, so 65 years and up are at greater risk for the development of heart failure. African Americans tend to develop heart failure more often than whites. Being overweight and being a man also increases your risk for development of heart failure. When you're looking at your risk factors, coronary artery disease, hypertension, a family history of heart failure, cardiotoxic drugs, smoking, obesity, sleep apnea, what kind of goes along with obesity, alcohol abuse, diabetes, and then children with congenital heart defects are all at risk for developing heart failure. Your manifestations for left-sided heart failure, you will see fatigue, activity intolerance, dizziness, syncope, dyspnea, shortness of breath, cough. They'll have orthopnea, which is difficulty breathing lying in the supine position, cyanosis. You will hear crackles and wheezes with auscultation of the lungs. You may hear a S3 gallop when you're listening to the heart. In right-sided failure, you'll see edema in the feet, legs, and sacrum if they are bedridden. They may also have anorexia, nausea, right upper quadrant pain, distended neck pain, and that's because of the increased venous pressure. That right upper quadrant pain is due to liver engorgement. Other manifestations that you may see are going to be weight gain and edema, and that's usually from increased sodium and water retention due to a decreased cardiac output. You will also hear they will complain of nocturia, which is voiding 2 to 3 times during the night. Paroxysmal nocturnal dyspnea is when they are awoken out of a sleep at night in acute shortness of breath. Dyspnea at rest and with activity is also another common manifestation. You may see or hear S3 and S4 on auscultation. So this is just showing you a list of your signs and symptoms that you may see with heart failure. And so you can see how the patient can be in great distress, especially when they're having an acute exacerbation. They can get very sick and have to be treated pretty quickly. Some of your complications are going to be hepatomegaly and splenomegaly, and that is from engorgement of the portal venous system. This leads to increased abdominal pressure and ascites. Impaired liver function is also seen. Dysrhythmias that further impair their cardiac output. You may also see pleural effusion and other pulmonary problems. In acute pulmonary edema, they will have dyspnea, shortness of breath, labored respirations, cyanosis. Their skin will be cool and clammy and diaphoretic. They will have a productive cough with pink frothy sputum, which is very specific for pulmonary edema. And that's because the little capillaries will actually rupture, and that's what causes the pink sputum. You will also hear crackles. They will be very restless and highly anxious because remember, they're basically just drowning, and so they're having difficulty getting all this out. I've actually taken care of a guy that we couldn't get the IV and the Lasix in fast enough, and he was coughing up just like clear water. So we were just making him just keep coughing, and he was just filling up emesis basin after emesis basin. And so that was a faster way for us to get some of it out because he was that full of fluid. All right, so when you're looking at collaboration, your main goals of care are going to be to slow its progression, reduce cardiac workload, improve cardiac functioning, and controlling fluid retention. So treatment strategies are going to be based on the stage. And there's a table 16-26 on page 1149 that talks about the stages. But basically, your stage 1 is a mild form and there's no physical limitations. They usually don't have any shortness of breath, noted with normal physical activities. And so recommended interventions for this stage is going to be regular exercise, smoking cessation, treatment of their hypertension and hyperlipidemia, discontinuing any alcohol or illegal drug use, possibly putting them on an ACE inhibitor or an angiotensin II receptor blocker or a beta blocker as part of their treatment regimen. Stage 2 is also a mild form. They have some physical limitations due to fatigue, shortness of breath, or palpitations. The client is usually comfortable at rest. Their interventions are going to be class 1 interventions, which ones we just talked about. ACE inhibitors or an ARB, which is an angiotensin II receptor blocker, or and a beta blocker as indicated. Surgical options include coronary artery repair and valve repair or replacement. Stage 3 is a moderate form. In this stage, they will have increased physical limitations, less than normal physical activity, results in fatigue, shortness of breath, and palpitations. The client is still comfortable at rest. Interventions are going to be the same interventions for stage 1. In addition of a diuretic, ACE inhibitor, ARB, and or beta blocker, to the medication regimen. Additional drugs may include aldosterone inhibitor, digitalis, hydralazine, nitrates, restrict dietary sodium, monitor their weight, restrict fluids as needed, discontinue drugs that worsen the condition. Surgical options may include biventricular pacing or an implantable defibrillator. In stage 4, this is a severe form of heart failure. Any degree of physical activity will result in increased discomfort. The client will exhibit symptoms of cardiac insufficiency at rest. Recommended interventions are going to be the same interventions used for 1, 2, and 3. Also, evaluation for available options out there. Interventions will include heart transplant, ventricular assist devices, surgery, research therapies, continuous infusion of intravenous heart pump medications, and palliative or hospice care. So that would be when they get towards the end stage of these of heart failure. So diagnostic test, your atrial natriuretic peptide. There's also a brain natriuretic peptide, which is a BNP. So your ANPs and BNPs are hormones that are released by the heart in response to changes in blood volume. Serum electrolytes are done to evaluate fluid and electrolyte status. Urinalysis, BUN, serum creatinine are used to evaluate renal function. Liver function test to evaluate heart failure effects on the liver function. Your thyroid function test, hypothyroidism and hyperthyroidism can have similar symptoms to that of heart failure, so you want to rule a thyroid problem out. ABGs are done to evaluate gas exchange. Chest x-ray can show pulmonary vascular congestion and cardiomegaly that is seen in heart failure. Your ECG can show dysrhythmias, ischemia, and infarctions. Echocardiogram is done to evaluate left ventricular function. All right, looking at pharmacologic therapy. Your angiotensin converting enzyme inhibitors, your ACE inhibitors, these will actually interrupt the angiotensin 1 from converting to angiotensin 2. It also blocks the renin-angiotensin system activity. It decreases the cardiac work and increases cardiac output. It dilates vessels, which increases the blood flow and decreases the cardiac workload of the heart. Your angiotensin receptor blockers, those are your ARBs. They don't block the production of angiotensin 2, but they do block its action. It slows the progression of heart failure, decreases their manifestations, and prevents complications. Beta blockers are used to improve cardiac function by inhibiting the sympathetic nervous system activity. It is used in low doses because it reduces the force of myocardial contractility. Diuretics are used to relieve the symptoms of fluid overload. Often they are treated with loop diuretics. That's like your furosemide. Your vasodilators help relax smooth muscles in the blood vessels, causing vasodilation. Examples are your nitrates, hydralazine. There is a new drug called Bidil, it's BIDIL, and that has been approved to treat heart failure in African Americans. Digitalis increases the strength of myocardial contraction and increases ventricular filling time. Your antidysrhythmics, your premature ventricular contractions are frequently left untreated because your antidysrhythmics can actually depress the left ventricular function. Your amiodarone is the drug of choice for your non-sustained ventricular tachycardias, though. All right, looking at nutrition and activity. They need to be on a sodium-restricted diet. It's usually 1.5 to 2 grams per day. Fluid restriction is done as ordered, and that will vary depending on the extent of the heart failure. Exercise intolerance is the decreased ability to participate in activity using large skeletal muscles due to fatigue and dyspnea. They need to be in a moderate progressive activity program. So they recommend aerobic exercise 3 to 7 days a week and include 10 to 15 minutes of warm-up with 20 to 30 minutes of exercise and then a cool down period. There's also surgeries that can be done to treat underlying cause, like if valve issues is the problem, then they can do valve replacements. They can also use the intra-aortic balloon pump or the left ventricular assist devices to rest the heart, and then heart transplants for end-stage heart failure is going to be the only curative treatment, but usually those are very limited due to the lack of donors. Complementary and alternative therapy. Complementary therapies include hawthorn, which is a shrubby tree that contains cardiotonic ingredients, and those are basically in their blooms, leaves, all that kind of stuff. But they will actually increase the force of the myocardial contraction. It dilates blood vessels and has a natural ACE inhibitor in it. Your coenzyme Q10s, magnesium, and thiamine are other medications that have been used to help treat heart failure. In the nursing process, you want to teach clients about coronary heart disease, the primary underlying cause of heart failure being coronary artery disease, as well as hypertension. Discuss risk factors for coronary artery heart disease, as well as ways to reduce them. And so those are going to be looking at more your modifiable risk factors. Assessment and health promotion, you want to instruct about coronary artery disease, helping to reduce those modifiable risk factors, hypertension and diabetes management. When you're looking at assessment and the health history, looking at complaints of increased shortness of breath, dyspnea with exertion, decreased activity tolerance, paroxysmal nocturnal dyspnea, how many pillows do they sleep on, because that'll tell you a lot about how they're breathing when they lay down. Is a cough present, weight gain, chest pain or abdominal pain, anorexia, nausea, history of heart disease or heart failure in the past, history of hypertension or diabetes. In the physical exam, you want to look at their general appearance, the ease of their breathing, monitor their skin and mucous membranes, monitor for jugular vein distension, monitor peripheral pulses and capillary refill. You also want to assess the amount of edema they have. Is it pitting or non-pitting? And grade it accordingly. You want to also monitor heart and breath sounds, as well as a good abdominal assessment. You may have to measure their abdominal girth, listen to bowel sounds, feeling for enlarged organs. Diagnosis, these are your NANDA diagnoses for heart failure. All right, and planning your goals may include that the client will describe the purpose of medication and report symptoms that need to be reported to the healthcare provider, maintain an adequate oxygenation, maintain adequate tissue perfusion to meet the body's nutritional and energy needs. Implementation. In maintaining cardiac output, you want to monitor vital signs, oxygenation saturation, monitor their BNP levels. Those are specific to heart failure. So if you have somebody that you suspect is in heart failure, you can do a BNP level, and it will show you how severe their heart failure is, because they can get actually pretty high, and just kind of shows how much fluid overload they do have. You want to auscultate heart and breath sounds regularly so that you'll know when there's any difference. Administer supplemental oxygen as needed. Administer medications as ordered. You want to encourage rest to decrease the cardiac workload. Monitor fluid volume. Assess the respiratory status at least every 4 hours. Most of the time it's done more often than that. You want to monitor their intake and output. And remember that 1 liter of fluid equals 2.2 pounds of weight, or 1 kilogram. You want to record their abdominal girth every shift. Measure their hemodynamic parameters as ordered, and then restrict fluids as ordered. Monitoring activity. You want to organize rest periods between activity, assist with activity of daily living as needed, but you also want to encourage their independence and don't have them just rely on you totally. You want to plan progressive activity. You can consult physical therapy who can help with that. Provide written verbal instructions about activity after discharge. Providing a low sodium diet. You want to discuss the rationale for sodium restrictions. Consult with a dietitian to help teach low sodium foods. They can also help with weight control in the diet if needed. In evaluation, these are your expected outcomes, that they can describe their medications and describe the symptoms that they need to report to the healthcare provider, explaining the importance of doing daily weights and keeping a log, choosing the appropriate low sodium foods from a list. They should also be able to modify their routine for adequate rest periods. All right, so this is the end of the heart failure lecture. And again, as always, if you have questions, let me know and I'll try to help clarify.